Today I'm about to talk about something that I think is probably one of the most consequential subjects in pediatrics, in emergency medicine, and global health policy. And it is about a hidden epidemic of complications of insufficient feeding in exclusively breastfed newborns. And I'm limiting it to term newborns because non-term newborns, preterm newborns are treated differently. But I'm going to give a trigger warning right up front because this is a hard lecture and there's some disturbing images in this lecture, but bear with me, it has an important message. I provided paid expert testimony on legal cases, including one of a couple in neonatal hypoglycemia and one of starvation death. 100% of those proceeds went to the foundation. And I am an unpaid volunteer director of the Fed is Best Foundation. An organization does not accept donations from any infant feeding companies in order to provide free, unbiased education on safe infant feeding. And so today we're going to talk about a case of starvation and dehydration in a exclusively breastfed newborn, the basics of feeding, fasting, and starvation, as well as the caloric and fluid requirements of a newborn. Why exclusively breastfed newborns lose weight and what happens if it is excessive, what the signs are of underfeeding and risk factors for breastfeeding problems, the incidence of feeding complications and admissions for these complications, and the long-term consequences of newborn jaundice, dehydration, and hypoglycemia. And finally, I'm going to talk about safe limits of newborn weight loss and how to prevent feeding complications. Goals of this talk are: number one, to protect all infants from suffering caused by prolonged hunger and thirst, to support breastfeeding in a way that ensures an infant's health and safety, to respect parent autonomy to make informed infant decisions that avoids risk and achieves optimal health for their baby, to reduce preventable hospitalizations, and to prevent infant injuries that can result in long-term disability and even death. This is a case of Landon Johnson, who was born to a G2P0 mother at 39 weeks, 2 days, born by C-section due to fetal intolerance of labor. The baby was born with normal APGAR scores and developed some transient tachypnea, and so was given supplemental oxygen and was stabilized in the mother in the special care unit and given IV fluid bolus. His glucose levels were monitored for 4 hours and they were stable, so he was transferred to the mother-baby unit to exclusively breastfeed with close monitoring from multiple health professionals at his baby-friendly hospital. The mother was very motivated to exclusively breastfeed. She took breastfeeding and parenting classes, read breastfeeding books, but she was a first-time mother, had an unscheduled C-section, had other risk factors like diet-controlled diabetes, breast hypoplasia, polycystic ovarian syndrome, issues with infertility. The first half of the first day was pretty unremarkable. Baby fed about every 1 to 2 hours, about 15 to 30 minutes. The weight loss was minimal. There was some early difficulty with latching, but ultimately that was resolved. The first 24 hours, the baby produced 0 wet diapers, but 4 dirty diapers. By the second day, the baby's feeding started to get longer. They were 60 minutes, really ultimately, eventually, continuously. The baby cried whenever he was unlatched. The baby had lost about 5% of weight loss by that second day, produced 3 wet and 6 dirty diapers. And then as the day continues, those feeds became really constant. The mother had expressed on the first day as well as the second day, why was her baby feeding so frequently and for so long? And she was assured that this was normal cluster feeding. By the second day of life, the baby had lost 9.7%. And about 10 hours later, the baby was discharged home. The baby was still latched to the mom's breast as she was being wheeled to the car. And then by the second day, the baby was crying whenever he was off of the breast, nursing nonstop. He was losing about 5% every single day. So if the baby's losing this weight, if the mother's milk does not come in and she has a pediatrician appointment the next day, what is that weight loss going to be by the time she gets to her visit? Yeah, about 15%. Baby continued to breastfeed continuously at home, and 12 hours later, he fell asleep. He was found 30 minutes later, limp, unresponsive, and blue. It's estimated that he was about 14% at the time he was found. So the father, who was a trained paramedic or EMT, started chest compressions at home, and EMS was called. CPR was continued into the ER, and 2 IOs were put in because the first one malfunctioned. He was intubated. He was found to be hypothermic. He was in PEA arrest. He got 7 rounds of epinephrine, and after 45 minutes of CPR, there was no return of circulation. And they confirmed no cardiac activity in ultrasound. It was this time that CPR was stopped with the consent of the parents. They were asked to say their goodbyes while ventilation and IV fluids continued in the background. And 20 minutes after cessation of CPR, he regained his pulse. He was diagnosed with hypernatremic dehydration and cardiac arrest from hypovolemic shock with a sodium of 155, and he was transferred to the nearest level 2 ICU. The baby was given dextrose and IV fluids and underwent a head cooling protocol and was evaluated with the MRI, showed injury to the basal ganglia of the thalamus and the brainstem. The EEG showed diffuse slowing and seizures with widespread injury to the brain, and ultimately the baby was taken off life support 19 days of life. The cause of death was hypernatremic dehydration, cardiac arrest, and hypoxic ischemic encephalopathy. This was the baby after resuscitation in the ICU and when he died. And this case is shared fully with the name on the request of the mother who wanted to share his story. So what was happening to this baby as he was cluster feeding and losing weight? What are the medical complications of underfeeding, its signs and its consequences? And at what point does underfeeding result in brain and vital organ injury, impaired brain development, and death? Let's go back to the basics. Living cells require a constant supply of oxygen, calories, and a specific fluid electrolyte balance to maintain cell integrity, function, and development. Some babies are born with low reserve, like small babies, premature babies, babies who are born through complicated and prolonged delivery, and some babies are born with high requirements, like those who are large and infants of diabetic mothers. As a result, the birth weight does not signify a full tank. A baby can be born empty. And so what happens if a baby is not getting their full caloric requirement? First, glycogen, protein, and fats are depleted, and this is what we call a fasting or catabolic state. And once glucose becomes depleted, ketones become the primary fuel of the body. And eventually, some living cells will die to release substrate to feed the remaining cells. This is called autophagy, which contributes to weight loss. Similarly, babies who are given minimal fluid undergo antidiuresis and decrease their urine output. But the research has shown that exclusively breastfed newborns, even those who lose excessive weight, will still produce urine. They will have diapers despite little to no intake. And so eventually this dehydration will lead to hypernatremia, kidney injury, acidosis, and hypotension, which reduces brain perfusion, which manifests as lethargy, which is a sign of brain injury and can quickly progress to cardiac arrest and death. It takes minutes of caloric deprivation to the brain to cause massive brain injury. And so this is 10 minutes of ischemia, what it does to 100% of brains, animal, human, and it takes 20 to 30 minutes of hypoglycemia that causes lethargy to do the same. And so if you're seeing a hypoglycemic baby who's lethargic and seizing, that may be a sign, likely a sign, of massive injury to the brain that can result in permanent disability. And this is also to remind you that time is brain. The longer the baby is exposed to that level of hypoglycemia, the more brain cells die. Another complication of insufficient feeding is hyperbilirubinemia or excessive jaundice, and that is also called breastfeeding jaundice or starvation jaundice. The reason why is bilirubin is excreted by the liver to digest milk. And so if the baby does not receive enough milk, that bilirubin accumulates. This is, of course, treated with phototherapy so that we can convert indirect bilirubin to direct bilirubin, which is excreted through the urine. But ultimately, excessive bilirubin can result in brain injury and disability as well. So why do exclusively breastfed newborns lose weight? In order to answer this, we have to understand first what is a caloric requirement of a term newborn baby. And that is 100 to 120 calories per kilo per day. That's provided by 5 to 6 ounces per kilo per day of mature breast milk or formula. And that's about 15 ounces per day, or about 2 ounces every 3 hours. That is the full requirement. And if they're fed colostrum, which in fact has fewer calories per deciliter, that they need more in order to meet that requirement. The maintenance fluid requirement is about 100 cc's per kilo per day. This is that meta-analysis showing the caloric content of colostrum. The first 4 days, it has 54 calories per deciliter, and thereafter, when the mature milk comes in, it's 66 to up to 77. When you calculate the number of calories that colostrum provides in those first few days, based on the average milk production, 24-hour milk production, that yields about 10% of that full caloric requirement, then 33, then about 2/3, and then the full milk requirement is provided once the milk comes in. Some mothers will produce more, some will produce less. This is a graphical representation of the percentage of that full requirement that they're receiving those first days of life. What does a newborn do in response to this? They lose weight. This is the weight loss nomogram of vaginally delivered and cesarean delivered exclusively breastfed newborns. Why does an exclusively breastfed newborn lose weight? The same way that we lose weight. Exclusive colostrum-fed newborns are losing weight because caloric and fluid content of colostrum they are receiving does not meet this full metabolic requirement. That is the reason why this period is called a time-limited duration of underfeeding by the Academy of Breastfeeding Medicine. And without supplementation, only the onset of full milk production saves them from this underfeeding. This relationship is illustrated by the study of almost 600 infants, measuring ketones or beta-hydroxybutyrate, as well as sodium and glucose levels at 48 to 95 hours. And it found that in this time frame, the vast majority of babies have fasting levels of ketones. This study also looked at sodium levels. So the higher the ketone levels, the higher the sodium levels. This study also found that hypernatremia was really quite common. The same way, higher the ketone levels, the lower the glucose levels. The higher the ketone levels, the lower the glucose levels. So that correlation between fasting, hypoglycemia, and dehydration. If the weight loss is excessive, really the main complications are dehydration, jaundice, and low blood sugar, which can result in brain and vital organ injury and eventually death. So what does newborn hunger look like? The first stage is really hands to the mouth, rooting, but eventually it progresses to crying, prolonged or frequent nursing, and then eventually high-pitched crying and continuous nursing. And so this is, go ahead, what that looks like. For any new person who's never taken care of a baby, this is something I teach moms, and this baby is gonna be offered a finger, and this clearly is a sign of hunger. Early signs include jaundice limited to the face and maybe cracked lips with poor skin turgor. The baby may produce fewer diapers, but we have very low thresholds for deciding what normal versus abnormal is. In this study of exclusively breastfed newborns, pay attention to the black bars. These are babies who lost excessive weight of greater than 10%. At day 4, they can still produce up to 6 to 8 wet diapers. And they can also produce up to 6 dirty diapers. And so what the study concluded that diapers are not accurate at all to determine whether or not a baby is adequately fed. The second stage of hunger is where they start to shut down and reserve whatever caloric reserve they have. They don't cry as much. They sleep more often. This can be mistaken as satisfaction from breastfeeding. There's blank staring, and ultimately they start feeding less, not waking spontaneously. And so this is a baby whose glucose was 11 and was in that state. Another sign is pink diapers or pink or red dust in the diapers. And these are urate crystals and is a sign of dehydration and hypernatremia. And another late manifestation, as I said, not waking spontaneously and lethargy. This baby was cluster feeding all day for maybe 4 to 5 days and was found 20% loss at day 5, lethargic and hypernatremic and jaundice. Sunken fontanelles is another last late manifestation. And this picture was posted on What to Expect by a mom who said her baby was fussing at the breast all day. And this is a picture of classic kernicterus. This baby is clearly dehydrated and severely jaundiced, whole body jaundice, with classic opisthotonus and retrocolus, which is arching of the neck and back. And this is what a seizure looks like in a newborn who's hypoglycemic. And this goes on to the point where a baby can be moribund and near death. And this is an 11-day-old with 33% weight loss, sodium of 180, potassium of 9.6, and AKI, very sick baby. The thing that these parents have in common are that they thought they were doing what was best for their children. What are the causes? Well, clearly there are 2 main ones: inadequate breast milk or poor latch and an ineffective transfer of milk, or both. And one of the most important ones, because it's the most common, is delayed onset of full milk production, or lactogenesis 2. So how many exclusively breastfed newborns are at risk? Even in the most ideal circumstance, a healthy mother who delivers a term healthy baby, more than 1 in 5 will develop delayed onset of lactogenesis. And if you have risk factors, the risk goes higher. First-time mothers who are over 30, those with flat and inverted nipples, those with high BMI, those who deliver with adverse circumstances, prolonged labor and having a large baby to a first-time mom, any higher BMI. Sometimes it's more than half of mothers have delayed onset of lactogenesis. As a result, exclusive breastfeeding at discharge from the hospital has been identified as likely the single greatest risk factor for hospital readmission and newborns, leading to a 2 to 11-fold increased risk of readmission for dehydration and jaundice, and a 2.3-fold increased risk for hypoglycemia. There has been a global epidemic of newborn jaundice since the standard of care has changed to focus on exclusive breastfeeding. 30% of U.S. term newborns now develop AAP-defined hyperbilirubinemia, whereas before, only 6% developed it. This is data from American Hospital Association showing that 78% of readmissions involve phototherapy. The literature has estimated about 5.7% of term newborns develop phototherapy requiring jaundice, and this correlates to approximately 190,000 U.S. admissions, either extended or repeat admissions, the majority for starvation-related jaundice. At 14,000 per admission, that's about $2.7 billion a year. The lifetime care of a disabled child is millions per child. And this is crazy given that almost all of these cases are preventable with reasonable, judicious supplementation with bank donor milk or formula. How many babies are being affected with hypoglycemia? So this is a study of 100 infants with hypoglycemia, looking at a threshold of less than 40, and they found that 10% of exclusively breastfed newborns develop hypoglycemia of this level, and 23% of first-time exclusively breastfed newborns, or firstborn exclusively breastfed newborns. A more recent study found that about 39% of term babies were developing glucose levels less than 47. How about hypernatremic dehydration? We've already seen that it's probably more common than we know. But before this standard, it was fairly rare. But since that time, multiple studies have noted its rising incidence. And now we actually know what the true incidence of hypernatremia is among healthy term newborns. This study of 165 newborns looking at universal screening of sodium levels found that about 30% of those infants were hypernatremic, affecting mostly exclusively breastfed and mixed-fed newborns. And likely the mixed-fed newborns were hypernatremic because they had crossed over, developing indications for supplementation. That means 96% of the cases were in breastfed newborns. And what was shocking to find in this study is that the weight loss that they were experiencing was not that abnormal. For infants who had these risk factors, male, born to multiparous or highly educated mothers, and we don't know exactly why that is, maybe as a marker for advanced age, and then C-section babies had a cutoff of higher risk of hypernatremia at about 4.8%, up to 10.8%. These are all normal weights that we believe is okay for babies to lose. So at what point does brain injury and developmental disability occur? Which is really the most important question to ask. Just to review, brain injury from hypernatremia can result in edema, infarction, hemorrhage, thrombosis of the arteries and veins, kidney injury, liver failure, DIC, and ultimately death. And this is one 15-day-old who was lethargic with 32% weight loss and a sodium 183. And she had sagittal sinus thrombosis, hemorrhagic infarcts, and edema. So this study of 100 hypernatremic neonates found that 45% had brain injury on MRI. It found mostly the lesions were visible around a sodium of 160. However, if you look at developmental outcomes, developmental risk happens earlier than that, about 150. So these are 3 studies showing the developmental outcomes of infants with sodium levels greater than 150. And 50% at 12 months had evidence of developmental delay, and about somewhere in the 12 to 25% range was present in the 24-month study and 36-month study. So it's not insignificant. This is an earlier meta-analysis showing, the reason why I have this up here is that each of these cases are a case of hypernatremia, and some of them can happen at less than 5% and some between 5 and 10%. Even brain injuring levels can happen between 5 and 10%. So what are the effects of neonatal hypoglycemia? This is a study that was done at UAMS. They studied almost 1,400 asymptomatic newborns, both term, preterm, every newborn, by 3 hours of life. And they found that exposure to 40 cc's, and all of them were treated, by the way, they found that exposure to glucose of less than 40 was associated with a 50% likelihood of passing the 4th grade proficiency in literacy and math. A glucose of less than 45 was associated with a 38% reduction in passing the literacy test. And even when the premature babies were excluded, that relationship persisted. This relationship is repeated in a population study of over 101,000 Swedish newborns, followed up at age 2 to 6. And they found every type, neurological, any developmental delay, motor and cognitive delay, increased with glucose of less than 40. Right now, there's a belief that transient, early, and asymptomatic hypoglycemia is benign and has no developmental consequences. This study also found that early hypoglycemia had increased risk of delay compared to later hypoglycemia. These are odds ratios, so this is a 3-fold increased risk of delay. And right now, we consider small for gestational age and large gestational age babies as at risk for hypoglycemia, and they get monitoring without symptoms. But appropriate AGA babies do not get monitoring, and in fact, their risk of delay from exposure to glucose of less than 40 is even higher. And probably the reason for that is since they don't get monitored or they don't get checked until they have symptoms, then they're not getting treated before the developmentally deleterious event occurs. The worst cases of hypoglycemia happen in infants who are symptomatic from hypoglycemia with glucose levels of less than 20. And this is a case series of 11 who lost anywhere from 0 to 16%, the majority losing less than 10%. 5 out of the 6 MRIs showed extensive brain injury to several lobes of the brain. And I talk about this because we need to drive home the point that losing less than 10% does not protect a baby. These babies went on to have developmental disabilities, epilepsy, hypotonia, visual impairment, feeding difficulties. And although parents or health professionals are commonly taught that hypoglycemic brain injury occurs in the occipital lobe, really they can occur anywhere. Anywhere in the brain is susceptible to brain injury from hypoglycemia. These babies were sick and non-sick newborns with symptomatic hypoglycemia of less than 47 with brain MRIs, and they found that 95% of those MRIs were positive for injury. They also went on to have developmental disabilities. This is a video of an MRI of a case I testified in of a baby who was poorly fed with a glucose of 16. And the white areas, very bright white areas, are the injured parts of this baby's brain. All of that is abnormal edema from injury, and maybe just this little part right here, that's normal looking brain tissue. And so that baby is severely disabled and will need care for life. All this to say is that hypoglycemia in newborns is common, but not benign, even asymptomatic transitional hypoglycemia. Low-risk newborns are also at risk for the developmental sequelae of hypoglycemia, possibly due to lack of monitoring. And if you're waiting for obvious symptoms to check a glucose, it's probably too late. Similarly, disability can occur from excessive jaundice. And a population study looking at the risk of developmental delay found that even bilirubin levels as low as 13.5 increase the risk of that delay, which can result in a more moderate syndrome of disability called bilirubin-induced neurological disorder, which can manifest as attention deficit, cognitive behavioral problems, seizures, up to cerebral palsy. And that more fits into kernicterus, which I'll discuss in a second. Data on serum markers of brain injury have shown that it rises at a bilirubin of 19 to 20. And at levels of greater than 25 to 30, then we get into the kernicterus range, which is severe disability that can result in a wheelchair-bound child who will need care for the rest of their lives. This is a baby who was born locally, whose mom was told to exclusively breastfeed and avoid formula at all costs. This baby was dissatisfied, and he was found 20% lost in 1 week with a bilirubin of 22. This baby is now nonverbal and globally disabled. This has been studied longitudinally into 30-year-old adults, and it found that this study of jaundiced newborns with bilirubin greater than 20 had a 4.6-fold increased risk of long-term deficits, including ADHD, problems with literacy and math, lower high school and college graduation, lower life satisfaction scores, and alcoholism. 45% of those babies were affected. So what are the safe limits of fasting a newborn? Now, what I'm about to share is what I have put together based on long-term data. They're not necessarily the current guidelines, which I believe are not protecting infants adequately. So what weight loss is safe? Since every baby is born with different reserve, there is no single weight loss that is safe. Every baby's threshold is different. This 10% weight loss is normal belief is a myth. There's no neurological data with developmental testing that has documented the safety of 10% weight loss. And only one study studying babies who lost greater than 12 at 5 years of age found that dehydrated newborns had reduced fine motor scores, higher rates of parental concern for language delay, and reports of allergies, increased allergies, and disability. But with that, we need to come up with some sort of guideline. So a weight loss of greater than 7% has been shown to increase the risk of hypernatremia and hyperbilirubinemia. And otherwise, 75th percentile on the newborn weight loss tool is a good threshold to start worrying and evaluating the baby. The Pediatric Endocrine Society recommends maintaining the glucose greater than 50 at less than 48 hours old and greater than 60 after 48 hours. What are the safe limits of bilirubin? Well, although the thresholds in the guidelines are higher, but according to developmental studies, probably the lowest risk bilirubin is a bilirubin of less than 14. But remember that injury starts to occur around 19 to 20. So how do we prevent this from happening? We need to respect infant hunger and ensure adequate feeding while supporting effective breastfeeding. So how do we do this? Number one, we need to provide intensive education to new mothers who want to breastfeed, not only on breastfeeding technique, but also the signs of underfeeding. We need to provide informed consent on the risk of brain injury and disability from jaundice, dehydration, low blood sugar, particularly if they are exclusively breastfeeding before the onset of full milk production. We need to assess risk factors for breastfeeding difficulties prenatally and during the birth admission. And finally, we need to discuss their desired method of supplementation if needed and how to maintain lactation while supplementing. All of these things can be found on this website with a feeding plan providing informed consent, the risk factor list, and all of that. These are the risk factors for feeding complications, which you can review on your own. So how do we make sure a newborn is fed? Number one, we can instruct mothers to confirm the presence of milk with manual expression of milk. Ideally, if the baby and the mom are stable, breastfeed within the first hour, assist the mom with correct latch and positioning, and confirm the presence of swallow and good latch using the latch system, which should encourage breastfeeding on demand, at least 10 to 15 minutes per breast every 2 to 3 hours. If the baby is weak, you can manually express during nursing to help the baby. But the reason why there are these guidelines is because longer and unsatisfied feedings can actually cause the baby to burn more calories than they receive during that feeding, accelerating their weight loss. Most of the time, babies are checked once daily. But if we're going by what the literature shows, the fastest losing babies lose 7 to 8%, which is the level of risk. Even weight checks of every 12 hours would eliminate that. And then these weight checks can be plotted on the newborn weight loss tool, which is available here. And then parents, those especially who are very motivated to exclusively breastfeed, there's all sorts of things that they buy to make this happen. They can monitor their baby's weight at home with a home scale. If the baby loses greater than 7% or greater than 75th percentile on the newborn weight loss tool, then it's time to evaluate the baby for signs of poor feeding. So you can evaluate the milk supply with manual expression or pumping, evaluate technique and swallowing, do a weighed feeding where the baby is weighed before and after a nursing session to see how much they're receiving. Laboratory data can tell you definitively whether the baby is getting fed or not fed, and that includes a sodium, glucose, or just a simple BMP, beta-hydroxybutyrate, which has been studied as an effective way of determining this, and then, of course, bilirubin if the baby is jaundiced or if there's doubt of whether or not they're jaundiced. And then maybe consider checking labs at weight loss of 5% for babies with these risk factors. Currently, healthy term exclusively breastfed newborns are at risk of hypoglycemia, but they're not being prospectively monitored. One way of doing this is not standard of care, but certainly has been studied in the literature, is to screen newborns within 1 hour after birth and then 6 hours thereafter, and then for any signs of persistent hunger. This can be corrected with oral dextrose immediately, but has to be followed up with some sort of milk. This oral dextrose will not stabilize glucose. You need some kind of milk to feed that starving baby. And then, of course, IV glucose for any severe hypoglycemia or lethargic baby. Bilirubins are monitored according to AP guidelines, but if you have a jaundiced baby, remember that bilirubin elimination depends on milk volume. And so phototherapy alone is not enough, especially if this is starvation-related jaundice. I recommend, and many people recommend, that you supplement to satisfaction. Only that baby knows how hungry they are. And it has been shown in the literature that greater than 6 supplemental feedings a day, or bank donor milk, whatever the mom chooses, per day, can reduce readmission rates by 76%. A Japanese study that looked at same method, supplementation to satisfaction, about 50 calories per kilo per day, about half of the requirement, eliminated the need for phototherapy completely. Other treatments, of course, are phototherapy and exchange transfusion. These are the indications for supplementations, the medical reasons, but of course, ultimately the parent's preference and signs of persistent hunger. The baby has the right to be fed. How do you supplement while promoting breastfeeding? Well, it's not rocket science, but to go over it, you supplement after breastfeeding. Make sure they're breastfeeding frequently, 15 to 20 minutes each breast every 2 to 3 hours, or based on hunger cues. Assist in milk transfer by manually expressing. Supplement only half an ounce at a time until newborn distress or medical indications resolve. And you can do this without a bottle. You can do this with finger feeding, with a 5 French tube, a syringe, a supplemental nursing system. Many ways to get the job done. Pause to assess for hunger, and if there is a missed feeding, pump the breast for 20 to 30 minutes. And for those who will be concerned about supplementation negatively impacting breastfeeding, there are 5 randomized controlled trials on the efficacy of 10 cc's of formula or donor milk after nursing for moderate weight loss. And it found that there was no difference in breastfeeding rates at 3 and 6 months. And one study, small study, found it actually increased exclusive breastfeeding rates. How many studies have shown that it reduced exclusive breastfeeding rates, that supplementation reduced exclusive breastfeeding? None. Not a single one. And this is illustrated by historical data, global infant feeding data in places where there is no formula, where breastfeeding is it. Almost universally, breastfed newborns were almost universally supplemented in the first days of life to prevent hunger, starvation, dehydration, and yet there was no impact to long-term breastfeeding. This is the median breastfeeding duration of these countries with these infant feeding practices, and their 1 and 2 year breastfeeding rates blow us out of the water. And in fact, this continues. This is more modern data. 75% of U.S. Hispanic mothers supplement with formula in the first days, and they have the highest exclusive breastfeeding rates at 6 months. They also have the highest breastfeeding rates at 12 months. The only one in second place would be Asian women. And so ultimately, the way you protect babies while promoting breastfeeding is provide prenatal education and assess risk. Prevent brain injury by supplementing before the complications occur if breast milk is insufficient. Maintain normal values, and protect the supply by supplementing after nursing. In conclusion, a newborn who is persistently crying and nursing or lethargic is hungry and is in danger of serious complications if not fed adequately. They need closer glucose, bilirubin, electrolyte, and weight monitoring. And a newborn can be supplemented to prevent these complications and hospitalizations without compromising long-term breastfeeding success. Starvation-related brain injury is a mistake that can never be reversed.